Okay, so let's talk about procalcitonin in 5 minutes, okay? We'll finish the whole procalcitonin in 5 minutes. So procalcitonin is is the pre-enzyme or pro-enzyme of a hormone of calcitonin, right? It's produced by the calcitonin is produced by the thyroid, right? But also it's produced by the white cells and some tissues. So that's why they came up with the procalcitonin. It's a marker for infection, bacterial infection. So what do we know about it? So basically there's some values that you have to remember. From 0 to 0.08, that's what they say the normal range. That's wrong. So in our lab, that's what if it goes above 0.08, they tell you it's positive, but it's not positive, right? The study is showing something different. In order to be positive is 0.5, right? I'm sorry, above 0.5, that makes it positive, okay? From 0.5 to 2, that's the gray zone. So basically you have to kind of look at the confounding factors, look at the other things, look at, and also look at the severity of infection and all this. It might be wrong. But above 2, you are guaranteed almost with a more than 90% positive predicted value that you do have bacterial infection. Okay? Now there is a little bit modification here. So they found also that 0.5 is correct, but only for any infection other than lower respiratory infection. So if you're looking for pneumonia, your cutoff is 0.25. Right? So that's the two difference here. So if you're looking for pneumonia, 0.2 above 0.25 might indicate that you have bacterial pneumonia. If you're looking for UTI and the number is 0.29, it is not UTI. It is not like bacterial UTI, or at least systemic bacterial UTI. Okay? So that makes it easy. Now there's other numbers. Okay, so we're going with the numbers now. Studies, there's at least 50 studies that I know of procalcitonin. There's more than this. In fact, it's the most ripe field. If anybody wants to do studies, if you want to pop in, this guy looks like a study guy. You know, so just keep studying. You know, if you want to publish 10 studies, do it on procalcitonin. I'm telling you, it's so amazing because we don't know anything. When we say antibiotics for 1 week, where does that come from? Where does that 1 week come from? Who came up with it? No, it came from the ID doctor's ass. When he was in the bathroom, he decided, the nurse is calling me. Well, how long we keep this antibiotic? Just 1 week. No studies whatsoever. We have very limited studies. Like for example, they showed that in VAP, you might actually want to go for 8 days. Okay, better than a week. Okay, whatever. That's one study. There's another study that showed that intra-abdominal infection, you might want to go for 5 days. 5 days is better or the same that 7 days. So 8 days for VAP, right? And 5 days for abdominal infection, right? All of this, the studies without procalcitonin. And then, you know how we say 6 weeks for, you have to do 6 weeks for, so this is with studies.
Osteomyelitis?
Yeah, 6 weeks for osteomyelitis and 6 weeks for bacterial endocarditis, right?
Sure.
Where does it come from? The same ass, right? 2 weeks for bacteremia, same thing, same problem. You know, that doesn't have any thing. They looked at, so that's no studies here, right? There's another one with studies, is that basically they looked at specifically Pseudomonas and Staph aureus infection in the lung, and both of them 14 to 21 days. Staph aureus and Pseudomonas. For some reason, they stick to the lung, they never come out, so that's why you like to go a little bit more than others. More than this, we have no idea so if you want to do a good procalcitonin, a good study, multiple of them, you can do it on procalcitonin. Just say any type of infection for hundreds of patients and see what's the average, time when the procalcitonin goes down, right? So let's see here. They did studies. We found out from the studies, if you have more than 5 procalcitonin, that rules. That rules out fungal sepsis, because it doesn't go up with fungus. So if you're like in a 3 range or whatever, you might have some fungal sepsis together with bacterial sepsis. Huh? But if you have more than 5, close the door please. If you have more than 5, you guarantee that you don't have fungal sepsis. Stop your antifungals. So that's very useful for us, right? If you have more than 10, right, the chances are more than 95% accuracy that you can rule out gram-positive infection. That's very good. So we change that in our practice, and when we see something more than 20, just to be sure. I don't want to stop the Vanco, more than 10. If I see more than 20, I'm almost 99% sure that it's not gram positive, it's gram negative. So I stop the Vanco and continue the Zosin, right? That's very useful, right?
Yes.
Okay, so these are the things, and of course, if it's more than 2, you can rule out viral infection. It's not viral, or it was viral and now turned bacterial. So these are the the numbers that you need to remember for procalcitonin. Okay, let me tell you a couple of things, because if medicine is that easy, everybody will be doing it. There's always like things that confounders and things that are doesn't go with the rule, like exception to the rule, right? So, for example, I've seen in certain cases, sometimes more than 20, in patients with endocarditis. With endocarditis, gram-positive endocarditis can have actually more than 20. So, just be aware. If you're not looking for endocarditis, then chances are you can stop the Vanco. Right? But if you're looking for endocarditis or the situation, you can still keep the Vanco a little bit longer just to see, right? I've seen that. I've seen sometimes cases with cystitis, especially cystitis. So one of the infections that raise the procalcitonin the most is gram-negative bacteremia, and so especially UTI, because UTI is very common to be gram-negative bacteremia. Especially UTI raises the procalcitonin significantly. So if you see something like more than 200, like the higher number, like more than 100 and whatever, we've seen more than 200. So anything above like 60 or more, that's probably gram-negative bacteremia, right? So so that's usually UTI, usually coming from UTI. But for crazy reasons, if you have just cystitis and it didn't make it outside the bladder, it's just very localized there, many times we see negative, negative procalcitonin. Not many times, like sometimes you see negative procalcitonin with just localized cystitis, right? So be aware of that, but localized cystitis is not going to kill the patient either, so if you miss it for a day or 2, it's not going to be a big deal, all right? So that's that. What are the confounding factors that can actually give you above 2 procalcitonin? Sorry, not above 2, usually within this range, like give you the gray zone, but they're not infection, all right? So renal failure. So somebody with renal failure, procalcitonin is excreted by the kidney, so it accumulates a little bit, right? So keep that in mind. Some people, but it's similar to troponin. You know how troponin, where does the troponin come from? It still came from the heart, but it's not excreted by the kidney. So this guy had an infection at some point, but it's not, it's not coming out, so that's why keeping it. Renal failure. Number 2, lung cancer. Adenocarcinoma in the lung. It actually can cause procalcitonin to rise. So actually that doesn't help us a lot when we have somebody with pneumonia or something. Is it pneumonia? And then this one I hate, pancreatitis. Because pancreatitis is one of the things that we like to use procalcitonin on, but it can give you something in between this, but it won't give you something in higher than 2, right? So the Department of Health here, or they like to do things like what do you call it? Like Department of Health likes to do the quality improvement projects, right? So they asked us once to send a quality improvement project. So all that I've done is just to send them. I sent them my just the practice that we're doing for procalcitonin. It wasn't written, so I just read it up quickly and sent it to them, and they were so happy with it. So we use procalcitonin for certain things. Number 1, and that's what's recommended by the company. What's let me tell you first. Forgot to tell you the protocol for procalcitonin. Okay, in order to rule out infection, procalcitonin takes 6 hours to rise. So you can't use procalcitonin. It's prohibited to use procalcitonin to diagnose septic shock or severe sepsis. You diagnose severe sepsis the same way we diagnosed before. SIRS criteria, blah, 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 suspicion of infection, all of these things. It's more to rule out severe sepsis or septic shock, bacterial at least, right? So so there's a protocol, and it's written here, our order set has procalcitonin times 1, and then like hour 0, and then hour 6, so two procalcitonin. The first hour 6, and then 4 days later. That's our protocol, and that's the recommended protocol by the studies. So the first 2 is to rule in or out infection, you know. So after you started septic shock, how long is the septic shock protocol? 6 hours. Yeah. So by the time you find the second procalcitonin, you're already done with the septic shock protocol. But at least it'll tell you don't continue antibiotics. It's negative times 2. If this is negative times 2, the chances of you having infection is 1%. Like literally, you can rule out, you can stop the antibiotics and sleep the night. You're perfect, just no problem. Okay? The 4 days is made to evaluate the length of the antibiotics, how long you're going to continue this antibiotic. You know, so in real life, we really don't wait for the 4 days. I mean, the floor probably can, you know. Here, the patient is so severely sick that we can't wait for 4 days to find out that we're not treating the patient. So most of the time, we order this, but most of the time we order a couple of, you know, in the middle, procalcitonin. So the first thing we use it for is to tailor the antibiotic, decrease the duration of antibiotics, okay? So what's the recommendation? If this goes down by more than 80% from this, you can stop the antibiotic. Imagine that. So if my first one is 100, and then it went down to 19,
Yes.
I can stop the antibiotic. This is nerve-wracking to me.
Yeah.
Because I'm gonna stop antibiotics when this thing is 19. It's too much, right? So what I do is that we changed our practice to a better practice, which is what? If the patient has dropped by more than 80% like this, we will take away 2 days of the duration of antibiotic that came from the guy's ass. You know, so if he says 7 days for pneumonia, and in 4 days, or in any day before 4 days, it went down by more than 80%, then I'm gonna give only 5 days for this patient. If I'm intending to do 14 days for bacteremia, I'm gonna go 12 days. And that's just a step in the way, you know.
Yeah.
The more studies it comes, the more comfortable we're gonna become. Number 2, we send it on all COPD patients. Every COPD patient that comes here, even if you don't have a suspicion of infection, we send it on. Why? The COPD lung is so hyperinflated to the point that that it hides infections. You can't see lobar pneumonia. It just goes between the alveoli and in the chest X-ray, you can't find it, right? So that's why the recommendation by the American Thoracic Society is to actually give antibiotics for everybody who's in COPD.
Yeah.
What antibiotic we use?
Azithromycin.
Azithromycin. Because it has also anti-inflammatory effect, and it's considered a mild antibiotic, right? We're not gonna get resistance and stuff like that, right? But in order for me to add ceftriaxone or not, I send the procalcitonin. If a procalcitonin is positive, and a patient will have COPD exacerbation, I'm just gonna do ceftriaxone. I assume that he has pneumonia, not bronchitis like azithro. Okay, so that's helpful for us. Number 2, something that is it's very contentious. People like fight over this: aspiration pneumonia versus pneumonitis. Right? So what's the recommendation? You people, some idiot, you know the Mendelssohn syndrome, right? The anesthesiologists know Mendelssohn syndrome. That Mendelssohn guy is a smart guy, but you know I think there's more damage that happened, more damage than none, because he had very healthy 20 pregnant patients that all aspirated. You know, they aspirated over time during C-sections. So they aspirated. He looked at them. The X-ray looks horrible, but he decided not to treat them because they did not have pneumonia, they have pneumonitis. But these people are MPO, they're in the OR, it's a very controlled situation. It's not like a 70-year-old guy who aspirates on his peanuts, you know? Like, you know, it's different. So they say, you know, you hear that, especially in the place that you worked in before, there's so much, what do you call it, pacifists. They don't like to do shit. So what happened is that in the medical world at least, what they do is that they say don't treat anybody if they aspirated, right? Wait 2 days, right? So if you wait 2 days and somebody in septic shock, for example, on pressors, or somebody who's intubated with respiratory failure, you kill that patient. It's too late already to start antibiotic on. So most people in the ICU, they do what? They say give the antibiotic and wait 2 days. After 2 days, if they're still having bad, infection or something grew or whatever, then continue the antibiotic. After 2 days, if the thing resolved and it looks like it's improving, then you can stop the antibiotic. We consider it pneumonitis. Well, we don't do that neither. We have a better situation here. We send the procalcitonin in somebody who aspirated, and if it's positive, we continue. If it's negative, we stop the antibiotic. Okay. Number 4 is pancreatitis. And that's why it bothered me a little bit that it does increase that procalcitonin. Pancreatitis is one of the most famous SIRS, right? So, it gives you fever, it gives you white count, it gives you tachycardia and everything. And patient looks like he's having infection and drops the blood pressure too because he's a hypovolemic, right? So all of these things are happening and you're like, oh my God, he's having infection, let's start antibiotics. And most of them don't need it, right? It's just inflammation. So that's the classic teaching. But a lot of them develop, tons of them. In fact, the most common infection in pancreatitis patient is pneumonia because they can't breathe. Like, so they start developing atelectasis and pneumonia. And the second most feared infection of pancreatitis is what? Necrotizing pancreatitis, right? So how do we know that they develop this? Just keep sending procalcitonin daily. If it's between these two numbers, you're gonna have to use your clinical situation. If it's above 2, start antibiotics. And just forget it. Start antibiotics, right? And then, so these are the 4 situations that we use procalcitonin uniquely. I mean, everybody else uses it, but we created protocols for this to actually make it, useful. Any questions about procalcitonin?
Yeah, I would like to know if in some way, the higher the values, the more severity is the disease, right?
Yes,
Yeah.
but it depends on the bacteria.
Okay.
So if it's gram positive, you're not going to see high values.
Okay.
It just doesn't give you high values. Gram negative, yes, you'll see it's a bit off the scales, but it's not an indication to admit somebody to the ICU. By the way, sometimes the hospitalist calls us and say, the patient has 105. Okay, but he's fine. He's eating. Yes, he does have gram negative bacteria, but treat it. But you don't have to admit to the ICU. Admission to the ICU, the same protocol that we do. By the way, I forgot to say, when you're above 20, we stop the gram positive coverage and we give 1 dose of gentamicin because we are worried about this bacteremia. If there's bacteremia, if there's any resistance, by the time you find out, you increase the mortality from 20 to 80%. If you miss bacteremia just for the first day, if you miss the treatment for bacteremia.
And in your daily practice, do you utilize these values to guide the duration of the antibiotics?
Yeah.
But how long do you keep collecting these values to decide when to stop?
Well, as soon as they start going down, then we just say, let's say something started at 5, okay? We give him antibiotic,
Okay.
and then we didn't grow anything, so we're gonna continue the antibiotic the same way, vancomycin or whatever. We'll just continue. That goes down to 4. Once it starts to go down, we don't have to send it anymore, but you just have to continue the treatment for 7 days if you're treating pneumonia or something. Yeah.
Even if this value keeps stable.
Well, no, stable, there's a problem.
Have decreased previously, but now it's stable. Like it was 5 initially, but now decreased to 4, and now it's 2.5, and keeps maintaining this value.
No, if it stays at 2.5, I have to think that there's something else is happening. I have to either send more cultures, change the antibiotics, whatever, until it goes to the normal range, like below 0.5 or below 0.25 if we're treating pneumonia. But if it's just going down, we're not sending anymore, and the patient is improving clinically, we can just continue 7 days and stop.
Okay.
Sometimes also, if the patient is not doing that great, we say after we stop the antibiotics, wait 1 day, send the procalcitonin again and see what happens.
Yeah.
Maybe it will rise again, and then we can then treat it.
Great.
All right. All right. So that's it. That's for the procalcitonin. Let's talk about antibiotics now. Look at this. Smudge all over the place. Maybe we use this solution.
Now it's white.
Huh?
Now it's white.
Now it's white.
No, the eraser stinks. You can watch what
All right. So when we talk about antibiotics, we have to we have to divide them. Classification is the best thing in the world, right? وعلمنا الإنسان بالقلم. That's classification, meaning that you have to classify it in your head. So the way I look at it is that you have to divide it into gram-positive, gram-negative, and anaerobes, right? So let's talk about anaerobes first. Very easy. Anaerobes, basically, we treat it with flagyl. That's the main treatment for anaerobes. Clindamycin is the second treatment of anaerobes, and these are the two that I consider mainly for anaerobes. Like these are the two antibiotics that you start because of coverage, because you want to cover anaerobes. All of the others that I'm going to write here are antibiotics that we start, but they have an anaerobic coverage in addition. So I never start Zosyn to cover anaerobes, for example. You know, like it would be stupid to start Zosyn just to cover anaerobes, right? But these are the two like specific for anaerobes. Flagyl is a little bit better than clindamycin. Flagyl covers all of the anaerobes. In addition to what it covers also bacteroides. So this one covered bacteroides, which is a gram-negative anaerobe, right? This one covers bacteroides, but not as good as flagyl. Flagyl has no resistance, for anaerobes, for bacteroides. So if you're wondering, sometimes the surgeons come in from the OR and they put the patient on, especially with gallbladder issues, they put them on Zosyn, right, or Unison. Zosyn and Unison, both of them have anaerobic coverage, and flagyl. It's like, why? Why you're giving Zosyn and flagyl together? But in certain cases, they might have, you shouldn't do it on everybody, obviously. It's just if somebody's like persistently having fever or whatever, then you say it must be a resistant bacteroides to Zosyn or Unison, okay? Then you add flagyl. Right? Clindamycin we'll talk about it in another, when we talk about gram-positive, but it is mainly gram-positive coverage, and then anaerobes with it too, right? It has also another quality, which is it covers the toxins, right?
Toxic shock syndrome.
So toxic shock syndrome and stuff like that. So actually, the way it works on the ribosome, so it doesn't produce the toxin anymore. So when we treat somebody with necrotizing fasciitis, right? These people have like multiple bacteria, vancomycin, whatever. But then when the bacteria dies, it's full of toxin. So it dies and the toxin goes all over the place. The patient gets sicker. So the way to do it is to give clindamycin at the same or before the initial antibiotic. Just shut down the toxin production and then kill the bacteria, right? So and usually I use it just for 3 days or something, and then you continue with the other antibiotics. Okay. Now, what are the other antibiotics that also have anaerobic coverage? Zosyn, which is piperacillin, right? And then we have Unison, also covers anaerobes. Augmentin, that's PO. It's the same, similar to the Unison, but it has also anaerobic coverage. And then cefoxitin and cefotetan. These are surgical antibiotics. They use it a lot in the OR. Cefoxitin and cefotetan for abdominal coverage. They cover only gram-positives and some anaerobes, and they like it because it covers anaerobes of the gut and stuff like that, right? So that's that. Okay, let's talk about so that's anaerobes, easy. Gram-positives. So when I think about gram-positives, you have to think about it this way. Two extremes. I have gram-positives gram negatives, and then the extreme here, MRSA, the extreme here, Pseudomonas. If you think about it this way, it's gonna be easy. This is gram positive, and this is gram negative, and this is Pseudomonas. Right? So basically, when you think about antibiotics, most of something when I say it covers gram positive, that means it covers this, and then you can then ask the question: does it also cover MRSA or not? And when I tell you an antibiotic that covers gram negative, it means it covers this only. But then you then ask the question: does it also cover Pseudomonas or not? So that's the extremes, okay? So let's talk about the MRSA coverage first. So MRSA coverage, first one is Vanco, linezolid. Right, and then we have daptomycin, and then cifteroline, and then we have clindamycin, doxycycline, and Bactrim. Okay. If anybody doesn't know the trade names, please let me know, because I know I use trade names. Unfortunately, we have to use generic names, but we don't do it. All right. So basically, all of them cover MRSA, but I have to make caution here. This is outpatient MRSA. I flip when I see somebody. There's a problem. Somebody made a study in the ER. There's a problem when you try to apply outpatient studies on the ICU, because ICU patients are extremes of the inpatients, right? So somebody did a study in the ER. They found, because people come in from the ER, they have cellulitis. So we used to treat the cellulitis with Unison, right? Unison have some gram positive, some gram negative, and anaerobes, perfect. But then the community is having a lot of MRSA now. MRSA is developing in the community, so people said, oh, there's MRSA in the community. So now every cellulitis that comes to the ED now has to be admitted or get a PICC line to get Vanco, right? So it's cumbersome. So somebody did a study and found out that clindamycin, doxycycline, and Bactrim treat MRSA, cellulitis MRSA. Great. Not in my hospital, not in my ICU, please. This is all outpatient studies, and in fact they showed that the outpatient MRSA has different genotype than inpatient MRSA. Like it's a different bacteria. So don't try to treat MRSA in a unit with doxycycline. You see it on the floor all the time. It's like the doxycycline for 3 weeks, and now he's still having pneumonia. Come to the ICU to get real antibiotics now. So.
There is cefalexin too, right?
Cephalexin?
Yeah.
Cephalexin doesn't treat MRSA. Cephalexin is like Ansem.
Maybe other, yeah.
Yeah.
Okay.
All right. So that's that. That's outpatient MRSA. This is IV. This is PO. This is PO. So I'm gonna say PO, IV, just so you know. And there's PO also, clindamycin as well. Okay. We're not gonna talk about those. All right. Vancomycin, it covers MRSA, but there is the lung penetration is a question here. How much can it penetrate the lung, right? So it's equivalent. It's like mediocre. This one is the best lung penetration. Linezolid, right? So if you have something that you really need to, like bad lung infection, that you tried Vanco, we don't try linezolid first because of cost, But if if I have my way, if I have somebody I know that is sick, I'm gonna give him linezolid, right? And okay, daptomycin has no lung penetration at all, right? It's deactivated by the surfactant, so you can't use daptomycin and whatever. Okay, cifteroline has good lung penetration as well. It might be 3 even like linezolid, but Okay, so that's the lung penetration. The next is PO or IV. So this is the only one that's PO. Everything else is IV. So that's an advantage here. Number 3, level. None of them has level except Vanco. You have to measure the level. And the level has to be 15 to 20. But there's something about the level that we actually, in the MIC, so basically when you look at I'm gonna say the MIC here. When you look at Vanco and you look at the MIC for Vanco, It turned out that the MIC is there's a lot of corruption in the MIC. I call it the MIC corruption, or the or my corruption. MI corruption, right? There's a lot of corruption there. The MIC is determined by the minimum inhibitory concentration is determined by the company that actually makes the antibiotic. So the company is the one that tells us what the MIC is. So it's in the best interest to say that the MIC is wide. Obviously, the FDA looks at it and looks at the studies, but you know, if you know what I mean, right? So, so there's a lot of, you know, like it's in the eye of the beholder. It's like, you know, on this plate, is this bacteria growing or not? Okay, fine. So, for example, just tell you the two examples that I know at least. I'm not an ID doctor, but vancomycin is found. So our MIC is 0 to 2, or less than 2, meaning that if you are so what is the MIC? Is that basically they keep diluting and finding out, you know, what's the minimum concentration that inhibits the bacteria. So if it's less than 2, the MIC, meaning that it kills with like very low concentrations, was 1.5, was 1, was 0.5, or all of this, that means a good MIC. That means you know when they give you the antibiotic, they tell you sensitive, S next to it, right? But they found out that anything above 1, the MRSA is only 15% sensitive to Vanco. So above 1, so between 1 and 2, this is a gray zone. Vanco is still killing the MRSA, but not all of it. It's killing only like 15% of it, and then the next day, and the next day, and next day. So it's not very effective. You know, it's almost intermediate. But that's not reflected here, or in any. They always go by the 2. So depending on your infection, if you're on the floor, or if you're going to go home or whatever, you put them on it doesn't matter. But if somebody's sick in the ICU with a MRSA, it says sensitive, right? And you look at it and you say, oh, it's 1. The MIC is 1. We're doing linezolid. Too sick for that, okay? Similar things happen with Zosyn, by the way. Zosyn, the MIC is 32 for Zosyn. And there was a big scandal, and they found out actually it's supposed to be 16, not 60, not 32. So again, if you have a gram-negative infection that is very severe, and the guy is like whatever, then yeah. Okay, so that's your Vanco. What else? Soft tissue. Which one is good in soft tissue infection? The best. These two are the best. This one and ceftaroline. They're all very good with soft tissue infection. Vanco have less penetration in soft tissue infection. Right? Bacteremia. Which one is the best for bacteremia? Daptomycin. Right? Daptomycin for bacteremia is the best, but it doesn't penetrate the lung. So if the bacteremia is coming from pneumonia, if somebody has pneumonia and bacteremia, don't use daptomycin, right? But if the bacteremia is coming from bones, whatever, soft tissue, anything, you can use daptomycin. It's very effective. Which one is the worst for bacteremia? Linezolid. Why linezolid? Because linezolid is bacteriostatic.
Yeah.
Right? So it doesn't kill the bacteria, just like kind of inhibit the growth. This one is bactericidal. This one is bactericidal. Vanco is bacteriostatic as well. Right? But you know, so for bacteremia is okay. I would say okay, but not. This is like bad for bacteremia. Don't use linezolid for bacteremia ever. This one you can, obviously. We use it all the time. Ceftaroline is good for bacteremia as well. Right? Now, so that's the general, like the choices and stuff like that. So when we talk about those, we're gonna have to talk about them. I like to do this. Gram positive, gram negative, just to get visual. MRSA, Pseudomonas. And we'll use another color, and we're gonna say these two. Okay, for Vanco. This one. Okay, and it covers these, but it also covers what? VRE. That's outside the box, right?
Oh.
So this is like even more specialized than Vanco, right? VRE is what? Vancomycin resistant enterococcus, right?
Yes.
All right. Okay. And then this one covers these positive, negative, MRSA, Pseudomonas. And it also covers these, and also VRE. Okay, but of course, different,
Yeah.
depending on what it is. MRSA, gram positive, gram negative. Pseudomonas. Covers also gram negative. And VRE. So, right, so the ceftaroline is wider spectrum than all of them. It's very, very expensive, we don't use it, almost, you know, like, it has to be like approved by ID and stuff like that. It's so much of a big deal. Okay, any questions about gram positives? Okay, so we're gonna erase this. I love it. I love the smudge. What is this, Professor? What is this board?
So bad.
It's dying.
Is this made in China?
Let's see.
We just got this board too, it's like.
Really?
I know, it's
the
a
end of
new
December,
board.
January we got it, it's not that old.
Okay, we can search the brand. It's Quartet.
No, listen, everything is made in China.
Mm-hmm.
Everything is made in China. And you know what we found out is that China has levels too.
Yeah, I know.
Like the Chinese product in Egypt is number 7 or something. Like, you know, it's like the lowest level of Chinese products come in the United States is number 1, right?
Yeah.
Right, Professor? You know that?
Yes, no.
Do you have a company that does this? He probably has it on the side. Probably has it on the side, just like he's importing medical equipment. Can you connect me with somebody? I need to get the BYD. The car. I need the car. The BYD.
Never.
Yeah.
You're never gonna do
I
it.
need to get it.
Yeah.
Can you connect me with somebody in China to get it or something? We can't buy it.
You need a BYD.
I need BYD. BYD is amazing. The cars are amazing.
No, it's recently on fire on the road.
It's on fire.
Yeah, electric vehicle is always on fire.
Oh,
Always on fire?
Like
Yeah,
legit,
that-
it's on
You,
fire.
Like, good.
you can see the news on the internet.
Oh,
You
really?
just
What
know.
what is your type of your car?
BYD.
oh, yes, BYD. Can I buy it from you? All right. Anyway, so let's talk about gram negatives. Okay. So before we talk about Pseudomonas. So we talked about MRSA, which is the extreme here. We're gonna talk about Pseudomonas, which is the extreme on gram negative. Okay. So Pseudomonas. All right. We're gonna start with. We're gonna say penicillins, right? 3rd generation penicillin. All right, that's like what the examples are. Zosyn. Zosyn is a penicillin, but you know, like. All right, and then we're gonna say 3rd generation cephalosporins. Right? Because this is Pseudomonas, right? You know, the 1st generation, 2nd generation doesn't kill this stuff, right? So 3rd generation is what? Ceftazidime. Okay? And then 4th generation cephalosporin. Yeah. That's cefepime. And then here we're going to write something else. I'm going to write it here so I can remember. 5th generation cephalosporin. No, that's it was ceftaroline, but doesn't kill Pseudomonas,
Ah,
right?
so that's called
Right? But there's other ones I'll tell you when you grow up.
Oh yeah, I only noticed.
All right. So 4th generation cephalosporin, and then we're gonna do fluoroquinolones. Like what? Like ciprofloxacin and levofloxacin. Okay. And then we have what? Gentamicins, what are they called? Aminoglycosides. Aminoglycosides, we have gentamicin, we have tobramycin, and we have amikacin. All of those are, aminoglycosides. And then we have what? Carbapenems. And these are the big guns, right? We have imipenem, we have
Meropenem.
meropenem,
Right.
we have doripenem. Okay, and then we have 5th generation cephalosporins, and we have 2nd generation, I guess, aminoglycosides. These 4 are very, very specialized, and I'll tell you why. Okay, so let's write the names here. This is called plazomycin, and this one is called cefderichol. Right? So they also kill Pseudomonas, but I'll tell you, they kill actually something that is more advanced than Pseudomonas. Okay. All right. So let's talk about Zosyn. So Zosyn does this. So positive, negative, MRSA, and Pseudomonas, right? And the way it works, it covers gram-positives, all of the gram-positives, imagine that? Covers all of the gram-positives, and the gram-negatives, all of them, and the Pseudomonas, all of them. The beauty of this classification is that when you say things that cover MRSA, all of them cover all of the gram-positives too. And things that cover Pseudomonas, all of them cover all of the gram-negatives. So you already got half of the things already, right? And then later we're going to tell you about the gram-positive and the gram-negative alone, by themselves. So it covers all of those, which is great. We talked about the controversy regarding the MIC. MIC is supposed to be, they said 32, it's supposed to be 16, so be careful with that. Zosyn is excreted by the kidneys, so you have to worry. What's the dose? Usually it's 4.5 grams Q6 hours. That's for patients who have normal patients. Right? That's the correct dose. You can go down if the kidneys malfunctional. You go down to 3.375 grams per Q6 or grams Q8 or grams Q12, and then you can even go down to 2.25 grams Q6, 8, 12, whatever, depending on the kidney function. Okay. We found out that all of the beta-lactams, including the penicillins, the cephalosporins, the carbapenems, right? All of them kill by what? By spending the most time above the MIC. They work on the cell wall, so they keep on just nibbling at the cell wall. So you have to give them more time above the MIC, right? You can't dip below the MIC for too long, right? So that's why what we do, we infuse them. So we give them as an infusion, not as like one bolus, right? If you give one bolus, it will go up, shoot up, and then go down below the MIC. Which one kills that way? Gentamicins.
Yeah.
Gentamicins, aminoglycosides, they kill, I call it the bazooka.
Yeah.
Like they're like a bazooka, like this.
Yeah.
This is the MIC, and you give 5 milligram per kilogram, huge dose. We don't give the 1 milligram per kilogram anymore. We used to give 1 milligram per kilogram every 8 hours, and we found out that it kills that way. So we do like, and then it goes like this. So that one time it goes above the MIC, it kills everything, professors. It kills even the human cells. It kills everything. It's just like there's a fight, and it wipes out the field. It just makes the field zero, and then we kind of fight again. So it gives time for the other antibiotics. That's why we give one dose of antibiotic of gentamicin. It helps us a lot. You just get over the infection a little bit, and then it goes down below the MIC for the rest of the day, and that actually helps with the side effects.
Yeah, toxicity.
So the toxicity happened because of the length of time above the MIC or above the certain level. So perfect. Even if we want to give gentamicin daily, we give it still with the same technique. Every 24 hours, 5 milligram per kilogram, right? Sometimes in renal failure, just because of it causes also toxicity of the ears, they don't hear, we give 3 milligram per kilogram in patients with renal failure, like severe renal failure. As opposed to these ones, they kill by the most time above the MIC, so we have to infuse them, right? But infusion is impractical because you're gonna occupy that line for Zosyn for like 7 days. It's like, come on, I'm gonna do like 2 central lines in everybody. So what we do is that we do every 8 hours infusion. So let's say Zosyn is every 6 hours. So I'm gonna do 4 hours of infusion, and 2 hours without infusion, and 4 hours infusion, 2 hours without infusion. So at least during these 2 hours, I give the potassium and the magnesium and use it for electrolytes and stuff like that. But during that time, the line would be occupied, right? But that made us run into a situation where, if somebody has infection now and I'm giving him the first dose of antibiotic, the bacteria is not going to wait for you until you build the level in 4 hours. It will chew up the patient, it will kill the patient, right? Every 1 hour delay in giving antibiotics in patients with septic shock increase mortality by 7 to 9%. 1 hour delay.
Yeah.
How much do they delay in Egypt? 24 hours. If we're lucky to get antibiotics in 24 hours.
Yeah.
Not in the big centers.
Yeah.
But in the villages, oh my God,
Yeah.
forget it. They live with the grace of God over there, I'm telling you.
Yeah, true.
They're very resilient, they don't die, it's just like,
Do that.
yeah. Or they die and we don't report them anyway.
Yeah, they do not.
So anyway, what I was gonna say, basically,
The infusion duration.
the infusion, right? So the first dose, the protocol that we're using here, the first dose that is ordered is giving over half an hour, and then 2 hours later, these infusion patterns start. So that's why it's a little bit complicated and it's in an order set and stuff. Okay, so that's your Zosyn. Okay, how about the third generation cephalosporin? Ceftazidime, right? I love ceftazidime, one of the medications I loved for a long time, but now I hate. MRSA, okay. What does it cover, ceftazidime? Oh, I forgot one of them. Aztreonam,
Oh,
by itself.
Yeah.
Okay, so what does it cover? It covers
Yeah, gram-positive, negative, Pseudomonas.
gram-negative and Pseudomonas. It doesn't cover gram-positive. It only covers 14% of pneumococcus,
Okay.
right? So that's a huge problem, okay? So Medicare or CMS, when they put the recommendation for hospital-acquired pneumonia, they said you have to give, an anti-pseudomonal, anti-pneumococcal antibiotic. Anti-pseudomonal, anti-pneumococcal, both of them. This is not anti-pneumococcal. So when we used that here, that was the one to be used. All over everybody was using Ceftaz at some point. But then they found that no, it's not anti-pneumococcal. You shouldn't use it. But we were using Vanco with it. So when you use Vanco, Ceftaz, Vanco is covering the pneumococcus, and this one is covering the rest. So it's still covered, right? So I was like against city MS. I was like, "There's idiots, blah 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 blah." But I think they had a point. The point is pneumococcus. The Ceftaz is bactericidal, right? Bactericidal, so it kills the bacteria. Vanco is bacteriostatic. So if I want to choose, I'd rather have what's the most common bacteria for pneumonia, whether it's hospital acquired or from the community. Strep pneumonia, pneumococcus, common in both situations, right? So if I give Vanco and Ceftaz, then I'm depending on Vanco, which is bacteriostatic. It builds a level, it has to build a level, it takes time, right? To kill the most common bacteria, that's bad practice, right? So that's why we don't do Vanco and Ceftaz anymore, right? We do Vanco cefepime, right? Because cefepime does kill pneumococcus and it's bactericidal, so we depend on it initially, and Vanco can be only for MRSA, basically, All right, so, but there is a practice that you might have seen in a certain hospital or many hospitals, you might have seen, because people misinterpret the studies. So there is a study that came out recently that showed that if you don't have MRSA in your nose, then you don't have MRSA in your lungs. People misinterpret the study like crazy. I laugh at this study anyway. I have to use it. I have to, because all of the ID people is like, they love to stop antibiotics. They are anti-antibiotics for some reason.
For resistance.
It's like, oh yeah, they're worried about resistance and bullshit, but they don't worry about this patient dying. It doesn't matter. But what I'm saying is that they want to stop the antibiotic. Okay, fine. We'll send MRSA. My trepidation is that I'm 100% sure I can show you the other study that was 5 years earlier that showed exactly the opposite. Is that MRSA in the nose and MRSA in the lung has no correlation with each other. So which study is better? It's just a study that I want to be, you know, like a study that fits my prerogative, you know, like it's crazy, you know. So anyway, so we're using that now. That's the push to use it. But people are misusing it. So for example, the study says MRSA and pneumonia, MRSA in the nose and pneumonia. So I'm treating cellulitis. I see people stopping the Vanco because there's no MRSA in the nose. What does it have to do MRSA in the nose with cellulitis? It's different, right? It hasn't been studied. That's number one. Number two, in a hospital that I know, I go to, I warned against it. They still do it. They do Vanco-Ceftaz. They didn't evolve. They're still using Vanco-Ceftaz, the old system, because they, you know, money and stuff like that, right? It's a for-profit hospital, so they don't want to. So they do Vanco-Ceftaz, and then when there's no MRSA in the nose, what do? They stop the Ceftaz. They stop the Vanco, which means what? We're not covering Pseudomonas. We're not covering pneumococcus. We're not covering pneumococcus. We're done. We're killing the patient, right? The saving grace for them. See, every idiot has a saving grace. Unfortunately, the human body is very difficult to kill. Very difficult to kill somebody, even if you try. You know, my attending used to tell me, "You guys, all of you residents, try to kill the patients as soon as they come to the hospital, but the patients are very resistant. They don't die." You know, so they use it, but the saving grace is that pneumococcus dies within 1 day. It dies very quickly, right? So Vanco in the first day usually kills the pneumococcus, and they get away with it, and they think that's like okay practice. It's not. It's not an okay practice. Anyway, so cefepime, it looks like this. Gram-negative and Pseudomonas, and gram-positive as well. All of the gram-positives. Very wide spectrum. That's why it's sometimes is described as a one like a monotherapy for neutropenic fever. Because really, I mean, neutropenic fever, I'm using Vanco too, but it doesn't matter. Sometimes you know, they like to play with patients' life a little bit and say, don't use Vanco. But you know, anyway, it's a very, very wide spectrum antibiotic, right? Both of those also are affected by the kidney function. You know, so we have 2 grams Q8, both of them, and we have also 1 gram Q8, and sometimes we do 1 gram daily if the patient is on dialysis and all this. Fluoroquinolones, so levofloxacin. Okay. So fluoroquinolones, it covers these, and also gram-positive. Very wide. Right? But also covers what? Atypicals.
Yeah.
So that's an additional. Atypicals are those bacteria, like, you know, the ones that we don't really think about it too much. Is Legionella, Mycoplasma. Mycoplasma is very common, by the way, but we don't usually treat it in the ICU. But you know, it's outpatient Mycoplasma. Walking pneumonia. Right? But unfortunately, both Cipro and levofloxacin, very weird. They kept their power against Pseudomonas. They're really still very good against Pseudomonas. But E. coli eats them for lunch now. Like, you know, there's a plate.
Yeah.
I'm the E. coli. I'm eating Cipro. Literally, it just doesn't work for E. coli. Like 40%. You know, so it's really nerve-wracking to me to use, and they're also bacteriostatic. So I don't want to use them in the ICU. I never almost use them in the ICU unless, you know, there's Legionella or something like that. Then I'm gonna use them. Okay. And it has all kind of bad rap because of the elderly and.
Tendinitis. You can't use them less than 18 or something like that.
Yeah, exactly. Yeah.
For the bone.
For the bone, for the very young and the very old, they're very bad.
Yes.
Right? Okay. Now, how about aminoglycosides? Aminoglycosides. Why is that? Why did that develop, by the way, in the fluoroquinolone? Because we used it so much. We abused it. Used it. That's why this happened.
Negative.
Right? So the aminoglycosides cover gram-negative and Pseudomonas, but it doesn't cover any gram-positive. But it's very strong because of their side effects. You know, they were used a lot in the past. Because of their side effects, we stopped using them for decades. They retain all of the power for Pseudomonas, 99% against Pseudomonas. So, and again, it's cidal, it's very, very good. So, you know, it still retained a lot of power. I use them a lot, especially tobramycin inhalation for patients who have Pseudomonas in the lung. It's off-label use, but we use 300 milligram BID inhalation, and that actually helps us with the zoosin and everything, just local and sometimes we keep it for 3 weeks and send them to rehab on it, right? So now let's talk about carbapenems. So carbapenems cover those gram-positive, gram-negative Pseudomonas and gram-positives as well, but don't cover MRSA. Very wide spectrum, right?
Mm-hmm.
But it covers something else called what? ESBL,
Mm-hmm.
right? Or now they call it MDRO. I don't know why they changed the name, but both of them are the same. Both of them mean the same. What is ESBL? Extended spectrum beta-lactamase producing
Mhm.
bacteria, right? So there is something called beta-lactamase. So beta-lactam is these antibiotics, 1, 2, 3, all of the penicillins, all of the cephalosporins, and this is considered also, these are the beta-lactams, right? There's penicillin and cephalosporin. So some bacteria have beta-lactamase, which is like what Moraxella. Moraxella always have, have and Haemophilus. Sometimes they have also beta-lactamase, meaning that it kills what? It eats what? It eats only penicillin. Penicillin and ampicillin, it eats these two. But anything else can still kill Moraxella and Haemophilus. They're very easy to kill, right? These bacteria. But if you have extended spectrum beta-lactamase, then it's eating everything. It's not, no antibiotic of this can work on them except carbapenems. It works on ESBL. So if you have ESBL, you want precautions. They call it now multi-drug resistance organism, which I don't know why, but whatever. Any one of those, put them on a precaution and do whatever. All right. Avipenem is falling out of favor because of the seizure. It decreases seizure threshold. So so meropenem doesn't do the same, and doripenem doesn't do the same. Okay. Now aztreonam. Aztreonam is almost the same like what? Like ceftaz. But because it's very rarely used and it's very expensive, it retains a lot of power against Pseudomonas, right? Now these two, plazomicin and cefderichol, they are introduced for something else that is very scary. And when you grow up, I'll tell you the story. Right? So they kill everything except MRSA, obviously, right? But they kill something called CRE, which is carbapenem resistant Enterobacteriaceae.
Wow.
So most of the bacteria that are ESBL, by the way, Pseudomonas is almost never ESBL. I don't know why, but the other Pseudomonas friends, which is Klebsiella, all of the things that comes from the gut, Klebsiella, Proteus, Enterobacter, not Enterococcus, and E. coli, right? These are the friends, right? These they call it Enterobacteriaceae, or the bacteria that comes from the gut, right? And these are the ones that they have like plasmids and stuff, and they develop resistance, so they become ESBL. So these are the ones that meant to buy this most of the time, and also they are the ones that after using this on them a lot, they develop carbapenem resistant Enterobacteriaceae. So they're the same bacteria, but levels of resistance, and these are the only two that we know now works on CRE. Right? So in 1 minute, I'll tell you a quick story, because it's really, I wanted to actually put it, if anybody's interested, just write it just ask ChatGPT to write it. It'll write it for you, put it in a poster presentation, and we'll send it to a conference. It's very useful knowledge for other people. It's bad for us. We don't look good. But anyway, so what happened is that during COVID, we were worried initially. It's like, COVID, what are we gonna do? The nurses were complaining. I can't keep, taking the gown, taking the thing, and come out of the room to empty the urine, and then come back, gown again, go inside the patient. It's like too much. So we decided I told them, and the manager and everybody said, well, the only solution here is to empty the urine in the sink, because we don't have any toilets, we don't have anything. Just empty the urine in the sink, NGs in the sink. So they did that, right? Meanwhile, a hospital in the same town, the competing hospital, they sent us our first patient of CRE. He was a patient of UTI, and he was in the ER, and they probably said, "Oh, we don't have beds. Can we send him there?" And we accepted the patient. He comes here, and basically, I've never seen this bacteria before. CRE, oh my God, we call it killer Klebsiella. Basically, there's nothing to treat it. These were not even available at the time. So he was like sitting there infecting everything in the unit. And anyway, at the end of towards the end of COVID, we noticed some people was like improving from COVID, but dying from another infection called like we found out CRE. The Department of Health came here and almost shut us down because it was like like they swabbed everything in the ICU, the walls, including my ass. They swabbed everything in the unit, right? And they couldn't find it. It's like, where is it coming from? You know, like it must be somewhere. And then some smart guy came from Atlanta, from the CDC, and came in and said, of course, it's in the drain. I said, what? So he swabbed the drains, and the drains have tons of CRE in it. And by the way, this is not the only hospital. It turned out that there's tons of studies published that the drains in old hospitals are full of resistant bacteria. Right? Anyway, so the drains turned out to be, because we emptying the urine in the drains, it started to develop there in the drains and became CRE. So now somebody opens to clean their hand, there's small microscopic splashes. It comes out on your hand, and then you infect the next person and the next person and the next person. So then we said, okay, well, we can't use the thing. We got somebody to actually treat them. So there's actually a treatment for it, and they go like flush them with chlorine and all that kind of thing. And we've been doing that for like before the fire, all the way through the fire until now. You know, treating and we finally got released this month. So okay, done. I bet you if they do the same for any other hospital, they still find it in the drain. But we were like the guinea pigs. But then we did something very intriguing and bad. We said, okay, well, we can't wash our hands in a room, and you know that C. diff only it's killed by what? By soap and water. It's not killed by Calstat, right? So we have to have a washing station. So we put one washing station by this corner here, by room 8. So every patient, we're assuming that every nurse will come out of the room from room 16 and walk all the way to room 8 and just wash her hand and come back to room 16. So then we developed another epidemic, C. diff epidemic.
Oh yeah.
So we had the two. So now we call it the CRE diff. Right? So it's not nice for the patients, but it's nice to know that what we have been doing was bad, and washing hands still works, and that's why we can demonstrate clinically that this actually happened in this hospital. All right, so quickly, what are the bacteria? We talked about MRSA, we talked about Pseudomonas. What are the bacteria that kills only gram-negative? You know, not Pseudomonas, just gram-negative. And these are, I'm just gonna say gram-negative here, gram-negative. All right, and these are, you see, we said third generation penicillin. We're gonna say here, second generation penicillin. Okay, and that's like what? Ceftriaxone. Ceftriaxone. Ceftriaxone is a workhorse. Ceftriaxone has been around for more than 60 years, and knock on wood, still no resistance. It's amazing. I mean, it does have resistance, obviously, but not as much. All right. Now, so we talked about this. So second generation penicillin, second generations. No. Why am I saying this?
Yeah, like ceftriaxone is not a second. That's not penicillin. It's cef.
That's like
It's
Unison.
third cef.
Yeah, Unison and Augmentin. Okay. This is second generation cephalosporins. That's ceftriaxone. Right. So ceftriaxone is cephalosporin. These are the penicillins, right? And then fluoroquinolones. Which one of the fluoroquinolones doesn't kill Pseudomonas? Moxifloxacin. I used to love this medication. Right? Moxifloxacin is very, very good medication for outpatients, right? Because it kills everything and it's PO, right? Aminoglycosides, there's no aminoglycosides that doesn't kill Pseudomonas, by the way. Carbapenems, is there a carbapenem that doesn't kill Pseudomonas? Yes. What is it called? Ertapenem. Ertapenem doesn't kill Pseudomonas. Don't be confused. Some people get confused about ertapenem for some reason, right? So second generation cephalosporins, basically they kill what? Negative, positive, MRSA and Pseudomonas. They just kill the negative, gram-negative, and gram-positive as well. So they just kill these two, gram-positive, gram-negative, but they don't kill the extremes, the MRSA and Pseudomonas, right? Both of those, they kill also what that we talked about before, anaerobes, right? Unison is what? Unison has sulbactam in it.
Yes.
Sulbactam is a weaker antibiotics that is added to the ampicillin in Unison. So Unison is ampicillin, but it's ampicillin sulbactam, right?
Yes.
And then pipe. Get out of here. Right? Augmentin is amoxicillin clavulinate. So
Yeah.
clavulinate is the same thing as sulbactam, but added to amoxicillin. So both of them are the type of penicillin, right? Ceftriaxone is ceftriaxone, obviously, right? We can remember we said cefotetan
Mhm.
and cefoxitin. These also are second generation cephalosporins. They also kill the stuff. So these two, they have this arrangement: positive, negative, Pseudomonas, MRSA, and the same. Well, they're both the same, really, and they cover gram-positive, gram-negative, and anaerobes. Ceftriaxone covers gram-positive, gram-negative, no anaerobes, right? So you can't use ceftriaxone to cover anaerobes, right? No anaerobes, right? Ceftriaxone has another great quality: good lung penetration, and also it actually, you know how it gets excreted? It gets excreted in the bile. So it gets, from the blood to the liver, and the liver excreted in the bile. So if you have biliary issue, you do ceftriaxone. In fact, they found that if you give so much ceftriaxone that we use, for example, in meningitis dose, you develop ceftriaxone sludge in the gallbladder, like sludge from the ceftriaxone itself.
Yes.
So great quality, just it clears the bile, really. So if I have a choice between ceftriaxone and flagyl versus unison for the bile, I would use ceftriaxone and flagyl for sure. I have this one concentrated in the bile, and I have flagyl that covers. Remember bacteroides that we said some bacteroides are resistant. It's much better than unison for the bile. So stuff like that. Moxifloxacin, it covers also gram-positive, gram-negative, but in addition to that, atypicals like these ones. So that's why it's very suitable for outpatient. You get pneumonia, give them moxifloxacin and send them out. Ertapenem covers everything that imipenem covers except Pseudomonas. It covers gram-positive, gram-negative, but it doesn't cover Pseudomonas. It doesn't cover MRSA, but it also doesn't cover out of those. See, the gram-positive is something exception here. It doesn't cover Enterococcus as well. So the difference between ertapenem and imipenem, for example, is that it doesn't cover Pseudomonas and it doesn't cover Enterococcus. That's what ertapenem is missing when you talk about ertapenem versus imipenem, right? Now, how about the gram-positives that are the antibiotics that cover only gram-positives? These are like, we don't have time obviously, so we'll talk about Ancef, cephalosporin, but that's the first generation cephalosporin. That's Ancef, or they call it Keflex, or they call it cephalexin, or all of these things are the same. Cefpidoxine, all of this stuff, and it covers gram-positive only. And that's why it's used, the most common antibiotic used in the OR, right? Because they want to cover bacterial, skin, right? And then, so that's the cephalosporin, obviously. That's the first generation cephalosporin. There's first generation penicillin, like what? Penicillin itself, or ampicillin by itself, right? These only gram-positive, right? And stuff like that. Okay, let's finish with a couple of things. What do you call it? Fungal infections. So fungal infections, we have fluconazole,
Yes.
right? We have caspofungin or micafungin, they're both the same, right? Voriconazole, amphotericin, we call it amphotericin. Amphotericin is horrible,
Yeah.
and there's something called ambizome. Okay, so fluconazole covers Candida, right?
Yes.
And not all the Candida, it's basically Candida albicans, which is basically the most common, Candida albicans, okay? Anything that is not Candida albicans, most of the time, Candida glabrata and Candida it actually cannot be covered by fluconazole for the most part. So we have to use caspofungin and micafungin, right? If you are going further than that, we're talking about aspergillus, right? Voriconazole can cover aspergillus.
Yes.
There's something about voriconazole. You can't use IV voriconazole for patients with renal failure because the solvent of voriconazole will accumulate in renal failure patients. So you have to use PO. So sometimes we use it anyway, but it's you just be aware of that. If you can't use voriconazole, and the voriconazole is not 100% really against Aspergillus, the best thing is amphotericin. Nobody uses amphotericin anymore. They put amphotericin in lysosomes,
Yeah.
and they let it be, it's a release over time. So it's called ambisome now. It doesn't give you the shocking fever, SIRS type picture when you get the amphotericin, because it's really terrible, so that's why nobody uses ambisome now, right? And last thing is what infections don't happen in certain places, certain infections are very common. For example, if you have a perforation above the ligament of Treitz, meaning above the second part of the duodenum, so esophagus, stomach, first part, second part of the duodenum, is full of Candida albicans. So these people get fluconazole, right? It's debunked and rebunked and all kind of thing. I just use it. Why not? We're never gonna grow it. It's very difficult to grow. So we just treat it. And we can depend on the procalcitonin as well. Patient is sick with negative procalcitonin, chances are it's fungal infection, right? But why wait? Just give it. Okay, so that's if there is perforation. Number two, Enterococcus doesn't infect the lungs for some reason. Enterococcus doesn't infect the lungs. Candida albicans doesn't infect the lungs, except if you're working in a bone transplant center. Anything can infect the lung. But in general, they don't infect the lung. Very difficult to find. If you find MRSA or Staph aureus in the urine, chances are it's coming from the blood. It's not a urinary tract infection. It's a blood infection that's going in the urine. Very rarely it's going to be just typical urinary tract infection. All right, that's it, professors. Any questions, professors?
Right?
Huh?
Amphotericin, this is the only one that you use for mucormycosis, you remember?
The Mucor.
Yeah.
I don't know. Do we use
You
that?
use amphotericin, I think.
Okay.
I saw it in the
Maybe, I don't know. I don't know if the Mucor, I call ENT. Remove the Mucor.
Come. Yeah, there is the brand, but I remember they were saying like amphotericin or something.
Yeah. All right. Any questions, professors, with the emphasis on fessors?
Good. So good, thank you.
We were gonna be from.
That one is